Bon, d'accord. À vous la parole, professeur Sinjab.
Thank you very much. Bismillah, assalamu alaikum. We can divide the complications after refractive surgery to keratoconus into 4 categories. Complications related to corneal cross-linking, complications related to customized laser vision correction, complications related to intracorneal rings, and complications related to phakic IOLs. Starting with the complications related to corneal cross-linking, you know that especially in the epi-off technique, pain is a very important complication. Delayed healing sometimes, especially if the stem cells already, there is deficiency in the stem cells. This is why we have to treat itching before doing cross-linking. We have to treat VKC, and we have to protect the stem cells from the cross-linking from the UVA during the UVA application. This is why it's important to use the PMMA rings over the stem cells to protect the stem cells from being destroyed. Infectious keratitis, which is something not related to cross-linking by itself, but to any corneal surgery. Reactivation of the herpes virus, leading to melting sometimes, stem cell damage, as I said, loss of 2 or more lines, especially if we are doing this with the epi-off techniques, endothelial failure, which is very rare complication, but it may happen if we don't adjust the 5 centimeter between the UV source and the cornea, and this may happen if we are very busy and leave the UVA application to the nurse or to the assistant. So maybe they will not adjust the distance very accurately. If it is very close to the cornea, then it will destroy the endothelium and may lead to scarring as well. Steroid infiltrates, sometimes we find it at the edge of the epithelium, that's healing, and haze. Now, we have to differentiate between haze, which is a normal process after cross-linking because of dehydration and low-grade inflammation, which is the interaction of the cross-linking, and on the other hand, the scarring process. So if you feel that the haze is not getting better by time and it is increasing and it started annoying the patient and affecting his vision, then it is a process of scarring. It is not a haze. So because the haze, which is a normal or natural side effect of cross-linking, usually does not bother the patient, does not annoy the patient. But if it does and it progresses, then we have to treat it as scarring by steroids. Complications after customized laser vision correction are unpredictable flattening effect of the cross-linking and the hyperopic shift, in addition to decentration. This is why using the customized laser, using the cross-linking as a prophylactic treatment in normal corneas is not scientific because of the unpredictable flattening effect. And some studies has reported a flattening effect up to 11 diopters. So there was a hyperopic shift up to 11 diopters. So we don't have a predictable effect. In addition, the customized laser vision correction should be aimed at treating the irregularities, not to treat the refractive error. We are not doing refractive surgery to keratoconus patient. We are regularizing the cornea and reducing the amount of high-order aberrations in order to improve the quality of vision. And we have to put in mind that when we are treating the astigmatism, we are treating both the real astigmatism and its shadow effect, which is the coma. So, for example, if the patient has -3 diopters of astigmatism, manifest astigmatism, It is not a real astigmatism. It is, for example, -2, in addition to -1, the effect of comma added to it. This is why in customized laser vision correction, usually we don't treat the full amount of astigmatism. Usually we treat about 70% of it, and we don't treat sphere to avoid such side effects. Now, decentration may happen, like in this case, due to the shrinkage of collagen fibers because of cross-linking. This is a case of keratoconus, and as you see, there was a decentration of the post-op optical zone, as you see here. The complications of intracorneal rings are asymmetry, interference with pupil zone, scarring, melting and protrusion, in addition to infection. Now, the asymmetry and interference with pupil zone are not complications. They are, unfortunately, they are like malpractice. This is because of the no experience of the doctor who is doing the surgery. Like in this case, I wonder why these two segments were implanted in this way. And if you look at the other eye, this is the same patient, look at the other eye, how these two rings were implanted. Of course, these two rings were explanted later because of this. The superior one is at the edge of the pupil, while the inferior one, it is within the pupil. So this is not a complication. It is not a side effect. This is because of no experience of implanting the intracorneal rings. Now we come to melting. If you see the white, a white material over the tip of the intracorneal segment, then you have to suspect melting. And later on, the intracorneal segment will protrude, will extrude outside. So, of course, this may happen because of shallow implantation. You know that we have to implant the intracorneal ring at least 75 to 80% of corneal thickness at the site of the tunnel itself. So if for some reason the measurements were not accurate or because of no experience, so in this case, the shallow implantation of the segments will lead to melting. And in this case, whenever you see melting, we have to extrude the intracorneal ring. We don't, or we must not wait until it extrudes by itself to remove it. We have to remove it immediately. Otherwise, if we wait, the eye is exposed to infection. Coming to complications of implantation of phakic IOL with keratoconus, we have the following complications: rotation, decentration, cataract, glaucoma, and infection. The cataract, glaucoma, and infection are general. That may happen either with keratoconus or not. But the importance comes with the rotation and decentration in keratoconus patient. Why? Because in keratoconus, the astigmatism is usually high, and it is irregular. And if there is even 5 degrees of rotation or misalignment of the axis of the toric IOL, phakic IOL, there will be new astigmatism and new refractive error. So this is one thing. The other thing is, before we implant the phakic IOL, especially if it is toric IOL, we have to be sure that the cornea is very stable. So if we have done to the patient like cross-linking, we have to wait at least 1 year in order to be sure that K readings are stable and the axis of astigmatism, corneal astigmatism, is stable. Otherwise, if the cornea is not stable and we implant a toric IOL, then the cornea will change and the refraction will change. So we will need to explant the phakic IOL. So we have to be sure that the cornea is very stable by monitoring at least 6 months, at least 1 year after cross-linking, with a 6-month intervals. Decentration may cause a disaster as well, especially if toric IOL was implanted. Thank you very much.
On donne la parole